Neurosurgery is a specialty that actually has a lot of variation in it, a lot of different options for PAs and NPs to work in. But it's also a specialty that sounds kind of scary and that a lot of people are kind of afraid to step into, thinking that they may be in way over their head. Well, the special guest I have today is a PA who's been working in neurosurgery for many years, and she's going to tell us whether it really is extremely difficult and terrifying or whether it is a manageable specialty with lots of job satisfaction. So, if you want to know the ins and outs of neurosurgery, then stay tuned.
I'm Sarah Maddux. I've been a PA for 16 years. I'm a wife. I'm a mother of 4 very active boys, and I have a total of 4 fur babies. It's a madhouse here.
That's a lot to keep up with and corral.
Yes.
Thank you so much for joining us today. And you are here to talk to us about the very kind of scary sounding specialty of neurosurgery.
Oh, I promise you it's not scary.
Okay. Well, that's what we're here to find out about today. Is you're going to kind of clue us in and let us know what it's really like to work in the specialty. Now, is the focus of your practice like just spine or just brain, or do you guys do a mixture of those two things?
My organization does a mixture of 2 things, but we PAs are assigned to a certain group. My surgeon works primarily only on the spine.
And what kind of cases are you seeing on a regular basis?
Well, I am an outpatient neurosurgery PA, so I see spine patients in the clinic.
And so these are people that have usually just coming in with like some chronic back pain type situation.
I would say about 80 to 85% of my patients are chronic neck or back pain. Some are acute, but those are more rare.
And do you guys handle like trauma patients, or are those usually handled inpatient with trauma surgery?
Where I live in Idaho, we have 2 different hospitals, and we are not the trauma hospital. So typically, trauma cases go to the trauma hospital, and we don't have as much of that, but we do still get car accidents. My surgeons take call and have to answer those calls.
Just in general, what kind of cases are usually being seen in the brain side of neurosurgery?
Epidural, subdural hematomas and follow ups. Brain tumors are a big one. People with Parkinson's needing deep brain stimulators is one that they see quite a bit of.
You said that your group, you guys put in spinal stimulators as well?
So my surgeon doesn't, but some
Oh, okay.
do. We
Oh, okay.
usually defer that to pain management since they do
Okay.
more of them.
Have you been working in neurosurgery the entire time in your career, or have you done other things?
I started out with our trauma team at the other hospital, so I got a good basis there of injuries, trauma. Of course, when you're dealing with trauma, a lot of that is neurosurgery. Then I did a year in ortho spine. And after that, I did urgent care, family practice, occupational health for about 5 years. I've been in my current position for 8.5 years.
So, in your knowledge, is it kind of common for a practice to be or a surgeon to be dedicated just spine or just brain?
In my experience, they're a jack of all trades. They'll do all of it. We're kind of uniquely set up because Boise is a booming area. And so it has allowed a lot of our specialists to kind of take on what they really like to do. All of us shine where we're at. One of my colleagues, all she does is the surgery part. And for my team, there's 3 of us outpatient PAs to support one very busy surgeon.
So, from I'm hearing from you that if you work in neurosurgery, a lot of times there is the opportunity to work either outpatient or strictly inpatient. But I assume that there's also practices out there where the PA is doing a little bit of both, correct?
Yes, I would say in your big cities, you're going to see more where people are able to focus more in neurosurgery, more as an outpatient or an inpatient or a neurosurgical ICU or surgical, just surgical. In smaller cities and smaller towns, they're everything to everybody. So they have to be more equipped to handle all things.
For the PAs and NPs who assist in the operating room, are they mostly holding retractors and doing suturing, or are they actually in there sometimes under the microscope doing things in the spine as well?
So they're under the microscope as well, holding retractors, suctioning. Our surgical PA sutures up the patients when they're done, puts in drains. She does the stapling, the bandaging. She's in the OR usually before the surgeon is, helping get the patient prepped and making sure everything is where it needs to be and ready for when the surgeon comes in to do the operation.
I want to talk about autonomy in neurosurgery. When it gets into specialties, sometimes it's very different than family practice. I mean, family practice, most of the time, PAs and NPs are, they have their own patient panels, they're seeing their own patients. Their patients never see the physician most of the time. But when it gets into specialties, it gets a little bit different. And every specialty operates and every practice operates differently. But in your practice, are you seeing new patients when they first come in, or do you only see them as follow up to the physician having seen the patient?
So I see new patients. I triage a lot of our patients. Typically, if we get a referral and it looks low likelihood that the patient will need surgery or they need more of a workup, they'll start with me or one of my colleagues.
Okay.
We'll get them properly worked up. My physician oversees my scans, so he reviews almost every MRI, CAT scan, EMG that I order, comments on what we found, what we want to do, and then I'm the liaison between the surgeon and the
Oh,
patient of the next steps. And if they go on to need surgical intervention, that's when they meet him.
if you're working outpatient, I like to give people an idea of what the hours are like. What kind of schedule do you have?
I have a pretty nice schedule. I have a very nice surgeon. I've got good colleagues, so we cover for each other. I work 36 hours a week, which is really advantageous with a busy family. I work 10-hour shifts Monday, Tuesdays, and Thursdays, and 6-hour shifts on Wednesdays. I'm off Fridays, which I call my mom day. It's my day to go to my health appointments, the kids' health appointments, and then I have my weekends. There can be 24/7, right?
Yeah.
There's those neurosurgical PAs that they're inpatient, outpatient, they work 7 on, 7 off. It can be pretty intense and it can vary all the way to my kind of schedule. Just depends on your surgeon. It depends how invaluable you make yourself to the team. I had to work my way up there. I did not start as a PA having those kind of hours. I kind of looked more like the 7 on, 7 off in trauma general surgery. But when you make a good reputation for yourself, when you work hard, you're able to negotiate those things.
And what about call? Like, is it common for PAs and NPs to take call in neurosurgery?
It is very common for us to take call. I don't. Like I said, I have a really sweet mom gig. Our surgeons take call. We have floor nurse practitioners who take call when we are off on weekends and after hours. It, we have a very dynamic team, which makes that possible.
So if people are looking to get into a practice in any surgical specialty, it is really advantageous to have a larger practice or at least a larger team servicing a surgeon, because otherwise you're going to be it, right? If it's just you and a
Yeah.
surgeon.
And some people love that life. I do not.
Yeah, yeah. And so what are the things that you love about the specialty?
I think there is this perceived prestige that, wow, you're in neurosurgery. And when you work in neurosurgery, you know a lot about very few things. But it's things people don't generally, as PAs, know about. There's perception that it's harder than I think it is. Most nerves, not always, we always have outliers, but they follow dermatomes, they follow rules. And if you know your myotomes and dermatomes and get really good at those, it kind of becomes rote. That's where I'm at in my career, where it's a rare day that someone comes in with something that's bizarre or I haven't seen before. Um, it's interesting. No 2 days are the same. You can come in thinking, oh, I'm going to have a very easy day. You're probably not. You could come in having, oh, I'm going to have a really hard day. This looks like a big day. And it just isn't. It's neurosurgery in a way is chaos. And so I don't know. I thrive in that environment because it's stimulating. I like a challenge.
And so when you say have a big day, like On average, how many cases do you normally see?
On a typical outpatient neurosurgery day, I'll see somewhere between 15 to 24 patients on average.
And that, like you said, that's a mixture of new patients and then also patients following up.
Follow up, post ops, new patients,
Yeah.
telehealth.
Are the follow-ups generally fairly quick and easy, which is why you can see that many in neurosurgery?
What I found interesting is very few are quick and easy. I love those cases. The patient comes in, they have an L5 radiculopathy, they have an MRI finding that correlates with that finding. There is nothing else wrong with this patient. Those are very nice and easy patients, and they're zebras. Most patients come in and have multiple problems, in my experience. Yeah, their back hurts. Yes, they have an L5 radiculopathy. They also have an L4 radiculopathy. They also have a hip problem. Oh, and also their neck is not doing so great.
Well, that kind of leads into the question I was asked, what is bad about working in neurosurgery? What are the problematic sides or the things that people might not like about neurosurgery?
I think some people don't do well in chaotic environments. You have to be willing to shift the sails. You could have a day where you think, okay, I'm set up with my surgeon. We're only seeing 11 patients. I needed this day because we have 20 case reviews. And then an emergency happens, and everything you were planning on is gone. And your surgeon's gone because he's saving a life. And patients are calling you wanting those results, which of course they do, but you don't have answers, right? And so you have to be really good at being tactful, kind. You know, these people are in pain, so they're not always kind back. That's probably the biggest challenge. Neurosurgery draws a lot of drug seekers. You have to be good about identifying who those people are, but also not jumping to false conclusions. It's an art and a science. It really is.
So in neurosurgery, do you end up prescribing a lot of narcotics or just what people need after surgery and then they go on to pain management or somewhere else if they need long-term narcotic use?
Yeah, I would say in my office, we are set up to manage postoperative pain outside of what we expect, 6 to 8 weeks. Then we usually hand them off to either their primary care or pain management, just depending which is more appropriate for the patient. But we tend to try to avoid long-term pain management. I know there are other clinics out in the US that kind of combine both because pain management and spine, right? That tends to go together. So sometimes you're working in both, but I am uniquely set up where we just deliver post-op pain medication. And then after that, we get them where they need to go.
So in neurosurgery, you're dealing with people that have these chronic back issues. And I think we've all worked around patients that have come back and said, oh, it just, I had back surgery years ago and it just made it worse. So do you see that a lot or do you see a lot of good results in spinal surgery?
I think the answer to that is a bit complex. Spine surgery, I have a saying for this, is kind of like a Lay's potato chip. You can't have just one. We know when we fuse a level in your spine that over time, above or below that fusion can fail. We can fix the pinched nerve problem, but what we can't fix is degenerative arthritis. And we know when we fuse, that seems to accelerate that process. Sometimes we have people with failed back surgery. We do see that. I think it's also a problem of not setting people, our patients, up for appropriate expectations. A lot of patients think a back surgery should be like getting a knee replacement. That's very easy for them to understand, right and left, and you either did a good job or you didn't. When you're dealing with a multi-joint organ, it's just a different beast altogether, and they are not the same. I would add that sometimes neurosurgery has a rap because neurosurgeons have a reputation for having difficult personalities and very big egos. Sometimes that's true. We all know neurosurgeons where, yes, that is true. I'm fortunate where I get to work with a team where they're not like that. They have really good bedside manners as well as they're good surgeons, and they exist.
So any tips for anybody when they're looking to interview with a practice? Anything that you think that people should ask or look for specifically to help them know if they're stepping into a good supported situation or if they're walking into a nightmare?
Yeah, I have some experience on this, so I feel good about answering it. If you, as you're keeping your finger on the pulse of what's out there for jobs, see a job that is always available and they're always recruiting and they're advertising a lot in your local media, it's probably not a great job, just from my own experience. If they don't have to advertise, if they're growing, if they're always hiring because the team went from 2 people to 8, that's a healthy environment. It tells you
Yeah.
something.
Okay, so what kind of personalities do you think do well as a PA or an NP in neurosurgery, or personality traits that would serve people well?
I would say you have to be organized. You have to be a good manager of chaos. All kinds of personalities do really well. I tend to be a little more neurotic. I have some coworkers who really just go with the flow. And it's really nice because honestly, if a patient doesn't jive with me, they'll do really well with my colleagues. You have to be a good patient advocate because your surgeon is probably very busy. But you have to be able to say, I know you're very busy and I know you have 3 emergency surgeries, but we have to review this case because there's surgeries tomorrow. And
Yeah.
that helps, being a good communicator, being a good advocate, being highly organized, all of that's going to make you successful.
So everyone is always curious about salaries, and like you mentioned earlier, neurosurgery is one of those that people think, it's up on that prestige level. But with that prestige and with that specialty knowledge, does the salary match that?
So there's all kinds of wages. When I looked at the AAPA 2023 salary report, neurosurgery can vary 95,000 for a beginning PA, kind of on the lower totem pole, all the way up to 200,000 just for base salary. That's not including benefits, that's not including bonus pay, RVUs, if you take call, that's just base salary. So it really varies.
Is it common in neurosurgery, in your experience, for people to get paid off of RVUs?
I know I do.
Okay.
I have a base salary in RVUs, and that seems to be what happens where I live. I've talked to other neurosurgical PAs. RVUs seem to be a way to motivate people to see more patients. So, a lot of organizations, I believe, are using that structure.
So if somebody wants to get into neurosurgery, what advice would you give them to help them prepare to be a good candidate and to get up to speed to work in a specialty?
Yeah, I would say foster your relationships with colleagues in neurosurgery. If you know a PA or nurse practitioner locally, that helps when you know people. It's always good to be highly educated in the specialty that you're trying to get into. So do your homework. Neurosurgery, I think that's more important than ever. They want to know that you know your dermatomes, just the basics.
Are there any particular, though, ways that you would suggest people get up to speed? Like you say, get up to speed in neurosurgery. Well, what if you're like, yeah, I don't even know where to start? Do you have anything you would send them to?
We use Greenberg's handbook for neurosurgery. It's kind of, our go-to, the number one thing, our number one resource. Whether it's brain, whether it's spine, it's a good resource. I I typically go on Mayo Clinic, look up things that you know. You know you're going to see disc herniations. You know you're going to see spondylosis, arthritis in the spine. Know what radiculopathy means. Know what the types of surgery that there are, like fusions or a microdiscectomy or a laminectomy, and how those are different, artificial disc replacements. Having just the basics of what we do is good.
So, what about the people who may be watching this who are pre PAs or are actually, starting PA school right now? If they can't get a specific neurosurgery rotation, what rotations do you think would be the next best ones to have that would kind of lay the foundation for them working in neurosurgery?
I didn't do neurosurgery for my elective either. I chose orthopedics, and I was lucky to work with an orthopedic group that divided between knees, hips, shoulders, and there was an orthopedic spine surgeon. So that gave me a good basis.
Is it really important, do you think, or very helpful to have just a general neurology rotation?
I don't think it's a bad idea at all to have a neurology background because people get confused and it can help you guide the patient to this might be more multiple sclerosis than cervical myelopathy. This may be Lou Gehrig's disease versus you have a disc herniation in your back. That would be helpful. I think having a general background helps as well because, like I said, so few patients come in with one issue, and you really have to compartmentalize them. This is your back issue. That's Raynaud's phenomenon. This is your hip. This is carpal tunnel.
Do you think that it would really be better for someone to have some work experience before they go into neurosurgery? Or do you think somebody can come out of PA school or NP school and do fairly well in neurosurgery?
I think it depends on the job and the surgeon. Some want to train up their PA exactly how they want them to do things. And so they tend to be new grad friendly because they want to mold. Some don't. Some are, they want someone well seasoned, experienced. They don't have to train as much and they're ready to go. They're ready to run. It's also important to look at how that team's set up. Do they have lead APPs that mentor the new grads? Do they have someone they can talk to help? Or are they kind of sink or swim?
Okay, so you've given us a pretty good idea of the ins and outs of neurosurgery. Anything else that you want to say about this specialty that people may find interesting or that may help them decide if this is right for them?
I would say if you like managing chaos and you're very good at compartmentalization, this is an excellent specialty for you. If you are good at following dermatomes, you're good at following, getting a good patient history, being a good patient advocate, and you're flexible, this is a great specialty for you. Despite its challenges, I find it very rewarding.
Well, thank you so much for taking your time and sharing with us and helping people get a glimpse inside of neurosurgery.
Happy to help.
If this specialty isn't for you, but want to hear about other specialties, then you can watch these videos here. You also can go to my main channel page and look at the playlist. I have cool and unusual jobs for PAs and NPs, non-clinical jobs, and also just general PA practice information. Thanks for joining me today. Take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.